All right, good evening, everyone. I just got done with treating patients. I'm sure many of you had as well. And we're going to get after talking about cementation here. So for those of you who don't know me, I am a general dentist out in Laguna Niguel, California. I like to do a lot of cosmetic dentistry. And I've gotten some little accolades after my name over many years of doing this. It's a pleasure to be working with Catapult, so thank you all for being present and watching this program. Catapult is trying to bring great education to people all over the planet, so thanks for checking in tonight. When we get done with this program, obviously we're going to have lots of questions, but as I know, there will be more questions that arise from having this discussion. So if you have questions after we're done, you are always capable to get back to me regarding this and other things. My information will be at the end of the program as far as my contact information and social media. You can see my email is here. So if you want a handout, I will have a handout for this program available tomorrow. It'll be at dentools.com. So you can see dentools is spelled with a Z. So this is probably the most important slide. If you want the slides, you'll need to go to dentools.com. But as Lisa had said, the program will be recorded and you can go back and watch it again later. So if you go to DenTools and put in your information and hit submit, you will go to a secondary page. That secondary page will say, hey, thanks for being here. Basically, you'll scroll down the page. As you scroll down all the way at the very bottom, when you get down there, will be numerous different lectures. You'll look for the one on cementation. So that'll be there tomorrow. Okay? All right. So what are you cementing with? Why do you use what you use? What are the benefits of it? How is it helping you? How is it hurting you? And so you probably have lots of questions. You've used a lot of things, and you may still have questions since you're listening to this program. So what I would tell anyone is to weigh the benefits of a bioactive cement versus a bonding agent and an adhesive cement. We have different options. There are reasons why we use one versus another. I don't think there's any one product in dentistry that is my 100% go-to every time for every type of case. I have numerous different products based on what comes up in front of me. And I know there are some dentists that like to do one thing for everybody, but I think that doesn't work as well as it could if you had different options for different scenarios. So anytime we're doing a preparation, we want to evaluate the preparation design for its retentive capabilities, its axial wall angulation, the axial wall height, as well as oral health of the patient, the type of moisture control we think we'll be able to manage, the type of tooth structure that's available, whether it's superficial tooth structure or deep tooth structure, in addition to looking at sclerotic dentin, or if we have a tooth that's been root canaled and we're working deep inside the tooth and it's had a lot of exposure to many materials over the years. There's a lot of things we want to evaluate about the situation, and that's going to lend us to our preparation design, as well as insight into what we might want to cement with in a couple weeks when this patient comes back. All right, so we have numerous different preparation designs, from inlays that are very simple to some that are more complex, to some where we're missing cusps, until we get to the full onlay. What I want you to see here is this. You have retention in some of these, and in one you don't. So in looking at these three, there is one that specifically must have phenomenal adhesion, and it should be obvious. It's the onlay. The other three have enough mechanical retention that you could put something in there and it would probably stay in place even if you have a cement that didn't have great adhesion. So you have an option on these to utilize a product that has great adhesion capabilities to hold the tooth together, or you could use a different product that actually has the ability to help mend the tooth and doesn't require as much adhesion to hold things in place. You decide what it is you want to implement, but nonetheless, you can start to see that based on preparation design, we have different options of adhesive capabilities or bioceramic cements, bioactive cements to implement. Now, in a case like this where we have minimal preparation of tooth structure, it's quite obvious. You're going to have to use adhesion. All right, so a bioactive cement will not have strong enough adhesion to hold veneers on. Now, maybe on a case like this where we have more extensive preparation design, maybe we have some crowns back in the premolars, well, now maybe we can start to use bioactive cements for some of these areas, and yet still haven't used adhesion in other areas where we have poor preparation designs that don't allow us to have good adaptation mechanical retention, right? Now we see here we have some crowns. Now we can go back to maybe using some other types of cements where we have, again, good mechanical retention. And on the veneers and the premolars and canines, we still need adhesion. So hence I said it's really important that you have more than one type of material as far as adhering ceramics to tooth structure, whether it's a cement or an adhesive resin, because we get all different types of procedures thrown at us. So for restoration placement, we have either a cemented group or a bonded group. And so the day you prepare the tooth, that's when you decide if it's going to be cemented or bonded. Now, I've seen people do kind of 3/4 crowns and they call them veneers. I might be inclined to take this a little more tooth structure way and have margins above the gum line and use a cement as opposed to an adhesive resin. Let's face it, if we're doing that much tooth reduction, it's not much more to go ahead and make a crown, something that's more durable and potentially has some good upsides to having removed a little more tooth structure. It's not to say adhesive bonding is bad, but sometimes a cement, I think, could be better, especially if you're removing that much tooth structure. So what I want you to get from this slide is you have margin position. The place that you put it is very important, because when you're cementing things in, you have the ability to maybe place something subgingivally and have a little better moisture tolerance compared to an adhesive resin, where when you start placing things under the gum line, very difficult to control moisture. So margin placement is more critical with the bonded restoration than the cemented. But with the cemented, you must have good retention because the cement isn't as strong. Versus if we have minimal to no prep, then we go to adhesives, because now we can go ahead and adhere things on to existing tooth structure and not worry so much about retention. Granted, I would say always build in retention no matter what your preparation design is, but nonetheless, veneers, no prep veneers, there is no retention. So trying to add it in is important because it helps adhesion last longer. So for cemented, our categories are basically resin modified glass ionomers and gosh, I'm having a brain stall tonight. Nonetheless, you have different cements there, bioactive cements. I put Ceramere since we're talking about that one tonight. So bioactive materials, there's numerous different ones on the market out there, but we're going to focus primarily on the Ceramere. As far as adhesive, we have self-adhesives, and then we have total etch and self-etch for our luting resins and bonding agents. So we have some different categories over there. So I broken it down into these 4 categories to try and keep it simple. I've put the glass ionomers in one area, self-etch resins in another. We have our bonding agents with resins in another category, and then we have our calcium aluminate, which would be our DOXA Ceramere. We have calcium silicates as well. So we have 4 basic categories we're going to look at here briefly. First one being glass ionomers. Obviously traditional glass ionomers, most of us aren't using these, but I want you to see that basically they have some components to them as shown here. They're acidic, they like moisture, they're made of basically moisture in a powder. They release fluoride, they degrade over time, low bond strength, but they do a good job of, being biocompatible and helping to seal the tooth. But add in resin and instantly they became substantially better. They're still acidic, they're insoluble, they like moisture, they're tolerant to it, they release fluoride, they're stronger than their counterpart glass ionomers. They do degrade over time, but they have improved bond strength, and their ability to seal a restoration when there's good retention is pretty good. So we can see the evolution of a glass ionomer into a resin modified, which gives us some great strength properties that many of us had used for our porcelain fused to metal restorations, and maybe even some of you are using it for your zirconia restorations or EMAX. But you have to have that good retention. Now, I mentioned ceramic primers there at the bottom because you can take a resin product and add in a ceramic primer, and a resin adheres to the ceramic primer, which allows it to adhere to a ceramic. And so we typically think of these with our resin adhesive restorations. But this will also work for your resin modified glass ionomers. Because there's resin present, you can use a ceramic primer. So if you have a difficult area that you can't do traditional resin adhesion and you want to use a product that has some ability to be flexible in a slightly moist environment, you might use resin modified glass ionomers. And to get better adaptation, better adhesion to your ceramics, you can add in a ceramic primer. And so we will get to those later. But realize that glass ionomers can implement those, or sorry, resin-modified glass ionomers can implement those. So ceramic primers we can utilize on all the different ceramics we use in dentistry. A ceramic primer is different than a silane. So our resin-modified glass ionomer cements, if we put a ceramic primer on the internal aspect of the ceramic prior to try-in, we can go ahead and try it in. When we're done trying it in, we can clean it off with some ethanol, and we can keep the tooth slightly moist, use the resin-modified glass ionomer cement, and we'll get a true chemical cure to the tooth structure, and we will also get the chemical adaptation to the ceramic primer, so it allows us to adhere to the ceramic. So this is one way to attack things in a moist environment. And this was probably one of the first bioactive cements we had in dentistry, and it still works well to this day. So I throw a couple slides in that you have as far as review if you go back and get a handout that I've basically given you a cookie cutter approach of how you might implement a system like this. So if I have a case in such a fashion where I'm under the gum line, hard to isolate, there's no way you get a rubber dam on there. If you try to use resin here, you're apt for failure in the future because it's going to fail right along that margin where you cannot stop sulcular fluids. And so this is a great place to implement one of the original bioactive cements being a resin-modified glass ionomer, and adding in maybe a ceramic primer. So here we have 2 zirconia restorations being adapted to the tooth with some traditional cements. Here's another example. Deep decay, sclerotic damage dentin. We're under the gum line. We have bleeding present. So we take impressions. We utilize lasers to control bleeding. Patient comes back after a couple weeks of healing. You can see we use the laser here. When the patient comes back, you can see the tissue is healthy from having utilized a laser. We know bacteria cannot colonize on tissue for 4 weeks or more after using a laser, hence we have healthy, happy tissue. And so for this, again, resin-modified glass ionomers may give us a great advantage here because of working in a moist subgingival environment. If you're going to try and do this with resin, you know the failure is going to happen because of the resin. There's no way to isolate this properly. So you can see this restoration going in using a glass ionomer cement. Very easy to clean up, as we all know, which makes it nice. We've all used these. So we know the fundamentals of using a simple product like this, and we know it can work very well. All right, easy cleanup, quick and simple to put into place. So I go back to these. There are times we need adhesion. Obviously, in the example I just showed you, we don't. And so, hence, we can't use resin-modified glass ionomer cements. So we start looking at resin options. So with your resin options, you have self-adhesive resins, and you have a bonding agent with a resin. Self-adhesive resins, they are somewhat acidic to neutral pH. They are not moisture tolerant, hence I'm talking about subgingival margins, or even if it's supragingival, if you can't isolate it, this is not the product you want to use. They have low to moderate bond strength initially. They get slightly stronger, but over time they decrease again. So you have a fairly inferior product that has low bond strengths, but there is adhesion. That adhesion will fatigue over its lifespan. It absorbs water, and its sealing capability is okay. So in my mind, this is a cop-out. I don't know why someone would want to implement one of these other than let me see how fast I can get something in that has a little bit of adhesion, and I'll move on to the next patient. In my mind, if you want something that has kind of lower bond strengths, I would go back to the resin-modified glass ionomer, because you get true chemical adhesion to the tooth, you release fluoride, you actually can help seal things better. And so by utilizing resin-modified glass ionomers, I think you get far better long-term success, better adhesion, and you have the ability to fight off cavities. If one wants to use resin, we're using resin for adhesion. And for adhesion, I would say as far as using something that gives me the best strength possible, the best longevity possible is what I would want in a resin, as opposed to a watered down version that has inferior strengths compared to its big brother when implementing a bonding agent. So if you're using a bonding agent with a resin, you still have an acidic to neutral pH. They're also not moisture tolerant, so you need to have very good moisture control, but they have incredible initial bond strengths, obviously, as we all know, and over time, like any resin, they will degrade and decrease with time. But you're starting with something that has initially a high bond strength that the self-adhesive materials just don't. Now, any resin is going to absorb water with time. They certainly have great capability to seal a tooth shut, And obviously, based on one's technique, you can get good results or bad results, the same as anything. So in my mind, you have kind of like a bioactive product on one end and a bonding agent with resin on the other end. And then you have a self-adhesive kind of in the middle where it's not great on either end. It's just there if you want to use something quick and easy. And so I throw some self-etch resin cements in here. And albeit they have done some great improvements compared to when they first came out, there's still some questionable capabilities of them as far as their long-term benefit to the patient. And so I throw some things in here as far as, number one, without a primer or bonding agent, they don't have the same ability to wet the tooth structure or to penetrate into the tooth. The acidity aspect of them from the acidic monomers inside of them, as soon as that acidic monomer hits the tooth, it starts to get neutralized quickly. And so unless you're putting on multiple applications of an acidic primer, it doesn't penetrate real far. And so again, you have the ability for this to utilize its acidity to grab onto the tooth. If you allow it to self-harden, it may work a little better. If you instantly hit it with a light, then how well does it really work? There's a lot of drawbacks with these. It's not to say they can't work, but there's a lot of drawbacks in utilizing these. And so knowing that you have a lesser strength initially and lesser strength over time, you may start to see restorations come off sooner than had you taken a few extra steps and introduced a bonding agent. They're both resins. It's just one extra step of rubbing some adhesive on the tooth structure, which honestly, the extra 10, 20 seconds, whatever it takes, I think is well worth it for our patients. So when you look at some studies talking about bonded resin cement, like you can see on the left side, versus self-etch auto resins on the right side, we obviously know we have poorer penetration of the material. We have higher penetration of microleakage over time. We see earlier failure. And so the question in my mind is, why do I want to set someone up for failure? Why not take a couple extra steps? Now, I realize it's a fast-selling, big-selling item, but again, you got to question why it's out there. All right, so that aside, we start looking at some of the strength properties of some of these, and I took this off of one of the manufacturer's websites. I'm not picking on any particular company because they all are fairly low in my mind, but they start talking about the 6-minute shear bond strength here, and they're saying, okay, we get as high as 6.5 megapascals. Well, 6.5 is pretty darn low, and when they say competitors are somewhere around 1 to 5, yeah, they're all pretty low. So yeah, they're slightly superior, but again, very low bond strength. You start looking, okay, 1 hour. Well, 1 hour it actually dropped backwards and the others started catching up. So they're still in the category of 4 on average. And then you jump to 24 hours and go, okay, great. There's a shift at 24 hours. So the patient, if they don't floss it and they don't eat sticky foods and beat things up, then some competitors will rise into the 7 and 8. And this particular product gets an average of somewhere around a 13. Now, 13 megapascals isn't that high. Okay, so again, 24-hour shear bond strength to zirconia. So the resin to the zirconia, you can see, has great bond strengths. And that's wonderful, great. Good adhesion to ceramic, poor adhesion to the tooth. So we can get microleakage between the cement and the tooth, and that's where we get a failure. Versus cement to ceramic, great adhesion, no failure, no leakage in between there by comparison. So high strength to ceramic, poor strength to tooth. If I was doing this to my family, I'd be a little disappointed. And so I would look at the patient the same way and say, why would I want to do that? When you read other research, it starts talking about these groups inside of these self-etch products being used as resin adhesive. They start to see that the shear bond strength on these is very low compared to groups where they actually implement adhesives. And so you start looking at these self-etching products compared to an adhesive resin and a dual cure resin cement. You'll see there's a huge shift in their durability and longevity. And so they're saying here the use of a self-etch primer on the tooth structure in addition to the self-adhesive resin cement significantly increases the shear bond strength of the all-in-one resin cements used in the study. There's companies like Panavia, Kerr, et cetera, that they have various types of primers, which is basically the first bottle in many adhesive systems, if they're 2-bottle self-etch systems. And so there is a capability in many of these chemistries where you can get a benefit. But in my mind, if you're doing that, you should have just used a bonding agent in the first place, a bonding agent that works with your dual cured resin cement, because there are different chemistries obviously out there. But when they're saying, oh, wow, it works better, well, why not just use better in the first place? We know they're inferior. Why go there? To save a couple seconds? I don't know. I just don't get the rationale behind it. And so it's kind of, to me, it's either you're going to do something really well or you don't. So having seen these, traditional resin cementation, conventional methods applied utilizing bonding of a silica-based ceramic are not always successful. You cannot acid etch and cyanate the internal aspect of metal oxide ceramics as you can with, let's say, like lithium disilicate or other glass ceramics. Hydrofluoric acid does not sufficiently alter the surface of metal oxide ceramics, and conventional silane coupling agents cannot provide chemical bonds to these materials because of the lack of silica. So with modern materials, we have some problems, right? And so there are ways we're all trying to get around them, but we know some of the traditional methods aren't working, so we have to have other aspects, and so we're going to hit on a few of these. Zirconia cases, when you have these aluminum oxide particles bombarded on here, we can actually change the surface and create small micromechanical capabilities to adhere to, but also creating more surface area. So ideally, your lab, when they're sending back your zirconia cases, they should be doing this for you. If they're not, you need to be doing this. Tribochemical is another way to coat these materials, these zirconia-based materials. And so alternative methods basically to allow us to adhere is bombarding it with these silica particles, and these silica particles are basically coated such that they're leaving a coupling agent, a silane, based on the internal aspect of the tooth from this bombardment coating process. And so there's different types out there. Rocketech silicoating has been around for a long time from 3M SB and has great results, but nonetheless, another step. And I know most dentists are like, well, I don't want more steps. Okay, so you probably don't want to do this one, but I throw it in there just so you have completion of knowing everything that's there. So at minimum, it should be air abraded, sandblasted. Now, prior to try-in, the internal surfaces of these materials, whether it be traditional ceramics, modern ceramics, zirconias, etc., all of these ideally with traditional resin chemistries need to have the internal aspect coated with a ceramic primer. Now, you may think of silanes, but ceramic primers are modern alternatives, modern versions of previous silane chemistries. And so these modern ceramic primers need to be painted onto your restorations prior to try-in. And what it helps to do is basically block out contaminants from getting access to touching the ceramic. So it gives you kind of like a layer of protection. It's not a guarantee 100%, but it gives you an advantage. And there's been articles showing this as well. So if you think of all the silanes that have been on the market that we've all used for many years, whether it's 1 bottle, 2 bottles, etc., these are great. You can still use them on, feldspathic porcelains, traditional ceramics, but there is a newer version of this same kind of process, and that's known as ceramic primers. Ceramic primers are unique in that ceramic primers typically are going to have a new chemistry inside of them, which is known as MDP. And so I've shown a few different ones here. On the far left, you can see MDP ceramic primers. In the middle, you can see certain ceramic primers that have silane and MDP mixed into them. And then you can see other categories where we have MDP inside of actual universal bonding agents. And so, like Visco, universal, fabulous bonding agent, love it. I use it all the time. It has the ability to adhere to ceramics as well as tooth structure and composites, etc., because of its MDP characteristic. So if you look at all of these down here on the bottom, they all have MDP. That is the ability to adhere to various ceramics as well as metals. Now, MDP, if you're not familiar with what this is, it was developed by Carrari back in '83. You probably remember Panavia being incredibly strong and durable. Well, it's because it had MDP in it. And so MDP is a monomer that was patented by them and developed by them, that when the patent fell, everyone else started being able to implement MDP into their systems. Hence, you have this massive flood of MDP into our materials, whether it be self-etch adhesive resins, whether it be our bonding agents, our ceramic primers, our resin cements. All of these materials now have MDP combining into them. Or I shouldn't say all. Many of them have MDP combined into them nowadays. So plenty of research, 20 plus years, incredible amounts of research behind it. One of the strongest, most durable materials that allows us to adhere to metal oxide ceramics, being zirconia, since most people probably aren't using or maybe even familiar with alumina. So a very strong capability to adhere to our materials. So this is the Carrari product, the Clearfield ceramic primer. There's no water in this silane with MDP, so it has less degradation. Again, they're the originators of the product, and so it's a very good product for adhering your ceramics when you're using your resins or your resin-modified glass ionomers. Now, Cleaning zirconia becomes another question that everyone has, and there's numerous different ways to go about doing so. And a lot of people think of Ivoclar's IvoClean, which is a great product. Basically, if you're not familiar with what it is, it's a zirconia oxide slurry. And by being a zirconia oxide slurry, when you put it inside a zirconia restoration, the concentration gradient is higher in this liquid that the phosphates want to leap off the ceramic, the zirconia, and jump into the slurry, and then you rinse it away. And so that's its whole purpose, is to strip off phosphates from saliva that have contaminated this. And so when you strip things off, if you had some ceramic primer on there, it would also help protect so it can't get in as easily. So it's not that you have to do it this way, but it certainly has shown some benefits. Now, there are other ways to clean zirconia as well. Let's look at this. If your zirconia is sandblasted from the lab, use a ceramic primer. You can clean it with ethanol. You can go ahead and clean it with IvoClean. You could go back and sandblast it again. And so you're going, well, gee, which way did I, just give me one way. Why do we have to have all these different options? There are different options because everyone likes to do different things. And so I'm showing you one way of doing it here, that if you ultrasonic with ethanol or used IvoClean, you wouldn't have to use any additional ceramic primer. But if you wanted to use a sandblaster, you could go back and hit it with the MDP ceramic primer again, because you will have stripped it off, obviously, with doing your sandblasting. And so you go, okay, I got these two ways. I've got IvoClean that doesn't require me to go back and put ceramic primer on again. I've got 3 different ways to do it. I'm getting confused, right? And I know it's confusing. That's why I'm showing it to you. And I'll continue on that path. If you have to adjust ceramic, people may ask, like, oh, well, what if I adjust it? The internal aspect, obviously, you're not adjusting. If you had to adjust it, you can, and then hit it with the air abrasion. But when I think of adjustment, I'm adjusting the outside. So people always ask, like, how do you adjust the outside? I use typically a fine diamond followed by some type of kit that's made for adjusting modern ceramics. So whether it's Ultradense on the far left is one of my favorites, or Clinician's Choice on the far right, their ASAP system, both of those are 2 of my favorites, hands down. So there's 2 options there if you're adjusting ceramic. We'll go back into the ceramic primers in just a second, but I want to hit on adhesion that ties into grabbing onto those ceramic primers. It'll make sense in a moment. So if you're using a ceramic primer, you're typically either going to use a resin modified glass ionomer, or you're going to use resin cements. And so what I want you to see here is all the adhesives that you can use. You'll notice many of these are now gravitating to having MDP inside of them. And that's, again, because of its ability to grab onto ceramic and to structure extremely well. It's not to say other products don't work well too. It's just the research behind this, we know they work very well. Doesn't mean that these products work with other manufacturers' dual cure resins. They all have different chemistries, as do dual cure resins. You got to be very careful on how you mix and match things, especially these single bottle systems. I would say, if anything, try to stay within one manufacturer's product line to keep your life easy, to have less failures. So when a product comes as a universal kit, as this one does, where you have a universal bonding agent, it's already been tested, it comes with its own ceramic primer, it comes with all the etchants you need, and it comes with both dual cure and light cured systems. Stick with one company's product. Don't try and mix and match a bonding agent to someone else's adhesive luting cements. You're asking for trouble. So I show this one here from Bisco for that reason, that you can get kits that come as a standalone, does everything, whether it's veneers or inlays and onlays, it does it all. And so again, one of my favorites here. So when we're talking about adhesion, we talked about self-etch adhesive, we talked about bonding agent with resins. What I want you to see here is this. These links work. If you get a handout of mine, it's a PDF, this hyperlink actually works. If you click on the hyperlink, it will take you to the research to read if you're connected to the internet when you're reading my handout. So we know that tooth-colored resin restorations have an average replacement time of 5.7 years due to secondary caries precipitated by bond failure. The weak link is our techniques in applying and moisture control. And so with any resin, we have failure because of those 2 items, which leads to secondary caries, which is why me talking about self-etch adhesive resins, I'm not a fan of as far as a all-in-one resin cement. I would rather use a bonding agent, try and get the highest bond strength possible, knowing that failure can occur over time. Now, what happens to resins? Resins basically have a challenge working in a moist environment. So grabbing onto the tooth structure with moisture being present, we know that the problem of resins absorbing water over time causes the polymer to swell, We get a decline in mechanical properties and a leaching out of the hydrolyzed resin, which causes failure. Let's face it, we've all had crowns come off with big bonded buildups inside of them. And as soon as you start cutting those away, the whole office smells from all the bacterial ingress because of the bond failure. That's not something you typically find with bioactive cements like glass ionomers and modern calcium aluminum systems. You just don't see the same ingress. Here's another research article by Pashley and Tay talking about bond degradation. We know that resin dentin bonds are not as durable as we previously thought. Granted, they're very strong, very great, but they do degrade just like everything else. And so we know microtensile bond strengths often can fall 30 to 40% in 6 to 12 months. And so we get a degradation in its ability to adhere to the tooth. Hence, I said you should always think about anytime you can put in mechanical retention to have less stress on adhesion as adhesion starts to degrade over time is important. And so we've all heard of the water tree effect. And so here's the article basically showing how in as little as 6 months' time, the hybrid zone is degraded from the left side where you can see the hybrid zone to the right side where it's gone in as little as 6 months. That is now no adhesion in that little area. And if that happens all across different areas of your interface with the dentin, this is where things leak, and this is where you have poor adhesion. So what's happening basically is you get 3 MMPs being released from the tooth, MMP 2, 8, and 9, when you have an acidic primer or a phosphoric acid or anything that has a pH that's under about 2, you get these release of these endogenous proteases, which start to attack your resin. So these are entrapped inside the tooth. And when you degrade the tooth with an acid, these get released and start attacking. And they break down the resin, so you have poor adhesion. And so what's interesting, if we look at adhesion, here's the dental students up at University of Pacific. This is courtesy of Dr. Mark Geisberger, who's on faculty up there. But the students get to basically take some dentin on an extracted tooth and adhere to it. And so they have this little button. This is the Ultra Jig, which is from Ultradent, obviously, hence the term Ultra. But allows them to adhere a button of resin that they put into an Instron machine, and they test their immediate shear bond strength. And if they want to store them for the night, they can do their 24-hour shear bond strength. But basically testing one's technique, trying to figure out how they can apply resin to the tooth and get their technique to be as good as possible and consistent, so that when they're bonding something in, they're able to get consistently high bond strengths. Let's face it, when you buy a bottle of bonding agent, you don't get whatever megapascal that product tops out at. If it's topped out at, say, 55 or 60, you don't get that. You have to strive to get it by doing good technique, good isolation. Okay, so it's not as easy as one thinks as far as adhesion. It's amazing to actually watch. So here's some of the bond strength studies from these dental students. You say, oh, well, they're students. These students are no different than any dentist. In some extent, I would say they're better because they're working outside of the mouth with no saliva or tongue, and they're following directions. And they're trying to implement every specific step across the path versus many dentists cut corners. And so looking here, we can see bond strengths anywhere from down at a 1 to a bond strength as high as 55. And all of these products we've probably all have used or seen at least, that these are all great products. And the bond strength of these being, over 50 for any one of them is amazing to see that you can take all these different dentists, or dental students, I should say, and some of them get great results and some of them get poor results and everywhere in between. As dentists, we all get the same thing, but most of us haven't taken the time to go test ourselves. So we have no idea what kind of bond strength gain we're capable of achieving. So this is enlightening that this is for all of us. On any given day, we can have great results or poor results. And these kids are trying to do well. And I've been out to Ultradent where I've watched hands-on where it's real dentists, and I can tell you the same thing holds true. You see guys that do great and guys that don't do great. But the great thing is watching people slowly learn, and as they learn, they get more consistent. Their bond strengths start to go up. Okay? So we know there's some fatigue in resin adhering to tooth structure when it's adhering to dentin, I should say. Enamel is obviously substantially better as far as its longevity and ease of adhesion. All right, so we're going back into zirconia for a second. So the zirconia Trian, I said a couple different things. I'm throwing them back in here again. Again, should be sandblasted when it comes from the lab. You should go ahead and put your ceramic primer on there. Now, after Trian, when it comes out of the mouth, it's contaminated. You got to clean it. So you clean it with IvaClean, you go back and resalinate or ceramic prime it again. Do your ultrasonic, stick in an ethanol. and have it ultrasonic or steam clean and then silane it again? Or do you sandblast it? Or do you silane it after the fact? Or do we use MDP-based cements? There's all these different possibilities that everyone's talking about, and it gets very confusing. All of these are plausible answers. But what answer could be the easiest becomes the biggest question. Let's look into this. Let's talk about this more. Because most of us just want to dive into resin every time. Go, oh, adhesion, adhesion. All right, so here's where we're working. We're working on the tooth. We're on the enamel. We have the highest longevity of bond strengths possible on enamel. But the highest bond strength potential on a tooth is actually on dentin. The highest bond strength you can get, if you do your job properly, is on dentin. Enamel will always be lower than the highest bond strength of dentin, but enamel has better longevity because there's no MMPs attacking it and breaking it down. So this is where you want to play. You want to be out here, like no prep, minimal prep veneers and onlays where you're on enamel. This is the best place you could ever be if you want longevity. But this is not where we get to play usually, because there's already been a cavity, a filling, a something there that we have to go into the tooth. As we go into the tooth, you can see here we're on superficial dentin. We have lots of tooth, small holes for the dental tubules, and not a lot of moisture out here. This is the highest bond strength possible is right here in this area. This is where you want to be. Hence, minimally invasive dentistry. But unfortunately, we have to go deeper many times. Now you have less tooth structure and bigger tubules, more moisture, more problems, more sensitivity. Go even deeper, down by the pulpal tissues. Now you have 3 times less tubular density than you had superficially, which means you have a lot more fluid, a lot more difficulty to bond to it. Your bond capabilities is now decreased by 30% with most systems just because of having less tooth structure and more moisture working down here. So you have a 30% drop off by working down here. So maybe a different product down here makes more sense, whether it's a filling or an indirect restoration, and scaffold it up and then start to adhere to superficial dentin where you have higher strengths. So we have these 3 different areas to work with. Ideally, we want to work on the far left on superficial dentin, but realize everywhere you work, you have problems. Hence, having different cements and adhesive resins is very important to your craft, okay? Because not everything works in all these different situations, because you do have different situations to contend with. Now, add into the fact you've got saliva and tongues and everything else, it becomes even more challenging. So full coverage ceramics with zirconia. I would say a bonding agent with a dual cure material that allows you to cure without the presence of light with an MDP-based ceramic primer is what you want to look for if you're going to have true adhesion capabilities, whatever system that may be. An MDP-based primer, they've shown great results behind it. You can read different articles. There's another article here, but basically says to adhere to zirconia, you need some type of MDP. I showed you Carrari's earlier. This happens to be Bisco's, 3M, Ivoclar. I don't care who it is, but any one of these shows you better results. And there's plenty of research to back these up. So adhesion to different types of materials, nowadays, your best capability is to use an MDP-based primer system. Okay, so I throw these again for you to go back and look at. And so I put in a cheat sheet here again as far as trying things in and implementing. Bisco, just like I'm saying, recommends using using a ceramic primer prior to try-in. And so I've listed it here for you. Why do they recommend that? The same as I'm saying. The research behind it is this. This is what I want you to see. Is there are numerous ways in which to treat zirconia after it's been contaminated, right? So let's look at the research here. This is one research project, and there's been others that basically back it up. So if you take a zirconia crown in the top left corner, and it doesn't have any contamination on it, this is our control, and you just put an MDP-based primer on it, your shear bond strength is 31.5. The next column down, if you take a same zirconia crown, and this time you contaminate with saliva, you clean it with water, and then you put a ceramic primer on afterwards, which you haven't cleaned off all the phosphates, but you cleaned some, you get a 20.6 shear bond strength, which is about a 30% fall off. Next category down, if you contaminate with saliva, clean it with ethanol, then throw MDP-based primer on it, you're still about a 30% fall off at a 20.3. So from there, use Ivoclar's product. You got it contaminated with saliva, use Ivoclean, use an MDP-based primer from either Ivoclar or any company out there, you're now up to 32. So does Ivoclean work? Sure. If you throw an MDP-based product on afterwards, you get a 32. You're back up to the control. So Ivoclean is certainly a way to go with an MDP-based primer. But what about if you got it contaminated with saliva, you clean it with a sandblaster, and then you put an MDP-based primer on it? Well, you're at a 30.3, significantly different from a 31.5 control or the 32? Not really, okay? So sandblasting is another way to go. All right, let's look at another example. Let's say the crown is treated with an MDP-based primer first, then it's contaminated with saliva, then it is cleaned with ethanol, and then it is not treated with any additional MDP primer. You can see it's a 28.8, which again, not really significantly different. So all of these can work. The easiest way in my mind to go about it is to coat it first, and then you don't have to go ahead and use IVOClean and sandblast and other things. So again, you choose what works best for you, but every one of these does work. So when someone says, oh no, you can't do it this way, you got to do it my way, do it this way, or the lab recommends it that way, you can see now why people are recommending different things, that they all can work. Just depends on what you want to have in your office. So you decide. Gordon Christensen talks about MDP-containing materials and how they bond to zirconia. I already told you about Panavia, but these MDP-based ceramic primers, we know that they have an excellent bond to zirconia, and that's why he's saying the same. But he does mention that some MDP-containing products were less effective because not all MDP is created equally. So keep that in mind. So bonded adhesion, I threw this together for you. At the very bottom on the far right, you can see the tooth, and you can see each step moving up through the system. So from how we treat the tooth, to the bonding agent, to the cement, to the primer, to the zirconia, all the layers that have to occur in between each one. So I've given you a cookbook kind of recipe here. So you can go back and reference this either when you watch the video again or get a handout. All right, so here we have a tooth, does not have good retention. We can get great moisture control. It's super gingival. And so we've sandblasted the tooth to clean any debris off of it. And we've gone ahead and sandblasted the internal aspect of zirconia. We've treated it with a ceramic primer. We're going to go ahead and treat the tooth with your bonding agent and your resin cement, a dual cure resin, so it cures in the absence of light. We can sandwich these together, and we can get great adhesion in an area that doesn't have great mechanical retention. If you look at it from the side here, we didn't go all the way up with our preparation design to create mechanical retention because that put us in the frication. So we're trying to save tooth. So zirconia, in this instance, bonded adhesion is the only way you're going to get that to stay. Okay, so we need that. Now, what about someone like this? You got a younger individual. She had an accident roller skating as a child. The teeth are badly damaged. The bonding's failing. She's had root canals in them. And you need to do something for her. By looking at this, you're obviously going to do crowns because you need something durable that's going to hold things together. So you go ahead and start working the case up. You start filling in holes so that you can take an overimpression. Having taken an overimpression, it allows you to then start working on the teeth. So you have captured the shape to make provisionals. So you do your ideal reduction. You're measuring along the ways. You're packing a cord. You're modifying margins. And you get to a point where it's time to take that impression. You capture that impression, and you put on some provisionals, right? Probably a face bow and documenting some shade, maybe for the lab, bite registration, same thing we would all do. What I question is, this patient being young, margins being subgingival, that you have to restore this, and you want to give this person something that's going to have great longevity. Being that you're on deep dentin, we know we have poor adhesion down there. We know adhesion fails over time. We know that MMPs attack my resin. We know that moisture control is going to be somewhat challenging because it's subgingival. Why not, when I take these temporaries off, use a product that is bioactive, that likes moisture, and is actually going to help that patient hopefully fight off cavities for many years, more so than any resin's going to do typically, right? So it's ease of placement, fights cavities, gives this young teenager basically a chance to get into, her later years of life without needing implants and a bunch of retreatments of the root canals. So in this case, we've used the Ceramir cement from Doxa. It's a calcium aluminate. We've got great looking results. Look at the tissue, how healthy it is, how it's grown up in between there. The bioavailability, bioactivity is amazing on this product if you look at the research. So here's where we started. Here's where we set her up for success for the rest of her life. So we're thinking long term. What would be better if I have good enough adhesive capabilities with a product that likes moisture, Gives me enough adhesion that if I don't have, you know, like, if I don't have the need for phenomenal retention, that I can use it instead. So we have a great preparation design, good axial walls, good angulation, good height. We can use something like this to give them a huge benefit. So what is this newer bioactive cement from Doxa, this Ceramere crown and bridge cement? Well, first thing you need to notice is it's alkaline. It has a pH of 8.5. Can you grow carcinogenic bacteria in an alkaline environment? No. So already it's got a leg up on every product out there that we've used as far as glass ionomers and resins. So you're setting a patient up already for success. Being that it looks like a glass ionomer capsule, it's a powder and a liquid. It likes moisture. It seeks out moisture. And so it's self-sealing. It likes moisture. It creates appetite. How many cements do you have that create appetite? Resins don't. So ability to create tooth structure, to self-seal, to like moisture, to fight off cavities, but also to be insoluble. There's no degradation. Gets stronger with time, which resins typically don't after the first couple weeks. Semi-translucent. Biocompatibility is excellent. And bioactivity also is as well, since it creates appetite. But here's the kicker. I talked about all these ceramic primers of MDP. I talked about conditioning things. I talk about adhesion and bonding and where to adhere and how difficult it can be and how challenging it is even for the best of us, but we'll never know it because we don't do bond strength studies on every tooth we work on. So you have all these challenges and problems. Guess what? The Ceramere does not require a ceramic primer or a silane, does not require conditioning of the tooth, does not require bonding to the tooth. I am not someone that takes the easy road out unless it's got fabulous research that proves that it is truly better than other processes that are available. So the Ceramere crown and bridge cement is indicated for porcelain fused to metal, crowns and bridges, solid metal crown and bridges, posts, inlays and onlays that are cast. If you have good enough retention, you could use it for ceramic inlays, but not onlays, unless there was a ton of mechanical retention. Prefabricated posts, strengthened core materials like all zirconia or all aluminum-based systems. Emax, lithium disilicate, lithium silicate, if you're thinking of obsidian from Glidewell. Stainless steel crowns, think of those kids and what a benefit they would have by having a cement like this to fight off cavities and in a difficult moving target that kids can be. But what about orthodontic bands and appliances? You can see where this material could go very far in the applications in your practice. So its ability to create hydroxyapatite is phenomenal. And so you have a leg up on all the other materials as far as cementing. Now, it is triturated, comes in a capsule. Because of that, you can't screw it up, or it's hard to screw it up, I should say. Probably still could. But nonetheless, it has a powder-liquid ratio that's already been pre-measured. So long as you mix it properly for the right amount of time, and it's not stored in an extremely hot environment, it's going to work quite well. You can syringe it into a crown very quickly and easily and apply it onto the tooth. If you're someone who doesn't want to triturate, they do have a powder liquid form that you could go back to old school mixing and try and stick in a centric syringe or put it in using a spatula. But I can tell you, majority of the time, anything that's been hand mixed or hand measured, we know always has potential for flaws. So do the right thing, get a triturator, and just mix it the good old fashioned way of the Wiggle Bug, or in this case, 3MSB's Rotomix. I throw this in as a comparison. This is a cheat sheet for you to go back and look on later. This is direct from Doxa. You can see how the Ceramere is compared to other materials we have on the market and how really nothing compares in its capability when you need a product that doesn't require you to have great adhesion for something like a veneer or an onlay. So for all your other cases where you have good retention, this is what I use. So let's look at an example. Here we have an existing crown. It has failing margins. And so we're going to go ahead and take it off. We're going to patch the areas that had decay and leakage with glass ionomers. And so at this point, you go, all right, I have to put a lithium disilicate crown on. I could use adhesion, but I've got some gingival areas. I've had some leakage in the past. Moisture control is kind of difficult. You know, I'm going to use this Doxa Ceramere because of its ability to not require a ceramic primer or silane, to not have to use bonding agent conditioners. It's fast and easy. Tooth needs to stay slightly moist. You don't want it desiccated or dried out. You want the tooth to stay moist because, as I said, this material seeks out moisture. So here's the final restoration dropped on there. So you got an Emax crown that looks great. It should perform a long time for this patient because of its ability to self-seal, to grab onto the tooth, to create appetite, and to fight off cavities. This bioactive material is the future of where we're at in dentistry. Now that means having good retention and resistance form. Now looking at comparison to self-etch, what I call lick and stick resin technologies, compared to glass ionomers and other resin systems out there. If you look at the retention of these crowns, these zirconia crowns, using these different materials, you see the doxyceramide does every bit as good as these other products on the market. And I'm not knocking these other products. I'm just saying that this becomes a very interesting aspect because these other ones don't give you the advantages that the doxyceramide is able to give you. Don't take my word for it, though. Two well-known researchers, Dr. Jeffries, Dr. Plommier, if you look at their 3-year study, they basically came back and said that at 3 years, their recall data yielded no loss of retention, no secondary caries, no marginal discoloration, and no sensitivity. All restorations were rated excellent for marginal integrity. This does not happen in dentistry. Every research project I've ever done at UCLA elsewhere always has failures. It's just by nature. So to have a product that is this good, that everything's coming back that successful, is amazing. Now, granted, technique error can come into everything. So again, preparation design, placement, if the tooth was desiccated when you tried it in or cemented it in, there are things that can happen if you're not following proper protocols. But nonetheless, when followed, phenomenal results with this. So at 3 years, no loss of retention, no secondary caries, no discoloration, no subjective sensitivity. That is phenomenal. The margins were excellent. So why is this material so different? What is so unique about it? We'll look at that in just a second. So here's the cementation technique. Tooth needs to stay slightly moist. I've tried it in the mouth. I can literally take it out of the mouth, blow the inside out with air. I don't have to go back and condition it. I don't have to use Ivoclar to scavenge it out. I don't have to use a ceramic primer. I don't have to do anything. The phosphates that contaminate the zirconia, I want to stay there because I need phosphate to create hydroxyapatite. So instantly, I'm not having to clean much. Tooth stays moist. I put this in. I hold it in place. After a couple of minutes, it's hardened and set. I then strip off the excess. I hold it in place when I floss it. Patient's done. And so I let this was one of the first ones I ever did. Sat there for 15 to 20 minutes. I then came back and cleaned it off. Very easy to clean off. Okay, comes off using a couple big pieces. What about zirconia bridges? Again, if you have good retention, there is no reason why you can't do this. Again, you don't need to clean out the internal aspect with phosphate scavengers, no ceramic primers. You don't have to etch and condition the tooth. There's no bonding agent, right? All you have to do is triturate this for 8 seconds, inject the material into the restoration, hold it down on the tooth for 2 minutes, and after 4 minutes, you can go ahead and clean things off. Very simple. Or sorry, after 2 minutes, you can clean things off, and at 4 minutes, it's good to go. So here's another example. Crown leaks and fails. They get a buccal cavity. Take the restoration off, obviously, to expose the decay, clean out the decay, fill it in with a glass ionomer to help remineralize the area to release some fluoride. We've got subgingival margins. The next person that goes in there puts another resin restoration. You're asking for another failure. So going in with a different type of cement, something that helps heal the tooth, a bioactive material. It likes moisture. It doesn't mind being under the gum line. Helps to fight off cavities. Okay, that's what we want to use for these. Okay, so whether it's zirconia, whether it's Emax, whether it's porcelain fused to metal, whether it's gold, all of these can be done. Here's a 6-unit anterior case that I did with the doxyceramide. You can see number 9 has a small chip on the distal aspect. I went in here and took this tooth off, replaced it for the patient. I had to cut this Emax into, I kid you not, like 11 or 12 pieces. It was not coming off. I was amazed at how durable this was. You take a glass ionomer or a resin. If you glued this on with resin, you cut it in half, hit it with a crown key, they usually pop off, right? Given enough time, those usually degrade and they'll pop off. Now, if you just cemented it in recently, yeah, usually you have to do the same thing I've done here. But I was amazed that it had that much strength. So you start going, all right, where else can I apply these? Well, what about implants? We all worry about having implantitis from, leftover cement, which you can see here. Took these off the internet, basically that this is a problem. And so here's an example for me. When I'm cementing things in for an implant, I'm using doxyceramide. And so for a case like this where it's subgingival, I get good healing, good tissues. And so I've adhered basically the two materials together. I got zirconia and the Empress crown. And so I don't see any cement here, but if there was, the good thing about it is it's bioactive. The body likes it. And so they've done research on this to basically show you can put this right on top of the pulpal tissues or on gum tissues, and it doesn't cause any change in the tissues. Rather interesting. So here we can see from the side, great tissue response, heals in nicely. Tissues truly like being in this area. So in looking at the study that Palmier and Jeffries had, if you look here at self-adhesive resin cements at the top, you can see at baseline all the way over to 31 days that if you have a gap between the test material and the dentin, this artificial gap will not fill itself in, whether you're using self-etch resin cements, whether you're using resin-modified glass ionomers or traditional resins. None of them will self-seal. But you look at these last two categories, and you go, okay, calcium aluminate, that's the doxyceramide. Well, notice at day 7, it's already sealing itself in. At day 23, it's filled in. Same thing with calcium silicates. So you're looking at something like viscose Theracal cement. And so you say, wow, at day 13, it sealed itself in. At day 30, it's sealed up. This is the newer generation that you really want to take a look at because of that reason. So a case like this, got to do a bunch of teeth. In the past, you'd have to bond all these in. And you know how much time it takes to do all this. To take a good preparation design, pack your cords, get a good impression, good provisionals. This is a lot of work. And cementing these in, they're coming for me. Cementing these in, would take a long time to isolate each one properly to truly do good adhesion. Okay? That's a lot of work. So to make life easier, to put all these in and deliver everything in an hour or less oftentimes is what I would like to do. Right? Wouldn't that be easy to change someone's potential life and longevity of the restorations, to fight off cavities, to create hydroxyapatite, to self-seal margin? That's what this product can do. So to change someone's appearance is what we've done here. We've used zirconia. We've used the doxyceramide cement. We have the ability to put it in a slightly moist environment. There's virtually no sensitivity. The technique is simple. The alkaline pH, apatite forming, insoluble, stronger with time, self-sealing. Why would I want to go back to traditional ceramic primers, resin adhesion, when I have something that does so much for me? In a case, again, that warrants it. Obviously, veneer cases and poor retention aren't going to warrant it. But when it is truly warranted, this is my go-to. And so you can see, having looked at other products out there, I have all these products. I use all these products for various reasons. But you can see my go-to for any time I have the ability to have good retention and resistance for them, the ability to put in every zirconia crown I put in, I'm using this. Many of my Emex crowns, I'm using this because I see the benefit of it for long-term for the patient's health. And when I don't have good retention resistance for them, when I do need to have good adhesion, then I jump into my adhesives and my dual cure resin cements. So there's a time and place for everything. I think you need to have more than one product. So dentools.com is where you get a handout. And again, as I told you, that will be available tomorrow. I have not put it up there yet. I will do it tonight when I get back home. So I've covered a lot of things. I've shown you some research behind why I do what I do, and it makes good sense to have different options that give the patient a huge advantage, but it gives you an advantage. You can work faster and easier, right? So here's a bunch of social media links for me. If you're on social media and want to follow along, love talking and sharing ideas. And so on the far left side, if you get this handout as a PDF onto your phone or computer, these hyperlink buttons do work. You can click on these in your handout. It takes you right to my social media, the same as the hyperlinks to different research that I had posted. And so realize that you have the capability to follow along there if you got a handout. If you want to just email me, you can see it's there. But if you go to DenTools, you can write comments in and ask for feedback or help or anything you want. Happy to help out. So that being said, let's take some questions. Let's see what we got here in the questions area. I manage a department with many different doctors and have found it important to keep things simple, which 2 to 3 products can all my doctors use. So I think you need maybe 2 different things, personally. I think you need a resin-based system that has good adhesion capabilities, and I think you need some other type of simple cement that offers a benefit. That could be a resin-modified glass ionomer. It could be a bioactive one like doxyceramide, or maybe you want to use viscose Theracal. There's other products out there, as I mentioned. Not a lot, but there are more coming, obviously. So I think you need something that has great adhesive capabilities. That's a resin, okay? And so that capability is when you have not a lot of tooth structure. You got to put a post in. You've got an inlay or onlay that needs better retention, or a veneer. Maybe it's a crown that has a poor clinical crown height. You have that aspect, but then you have others where you go, you know what? I got great retention. This doesn't need the resin material. This needs something that's going to give it the best longevity possible to help fight off cavities. And that's where I'm looking at more of one of these bioactive materials. And so another great question comes up. So the next question is, how is Ceramir better than an RMGI? Perfect question. So resin modified glass ionomers, as phenomenal as they are to like moisture, to release fluoride, they don't truly fight off cavities long term like the Ceramir because of its alkaline pH. They also aren't going to create your hydroxyapatite. They also will not self-seal a margin, and they do degrade more so over time. Okay, so resin modified glass ionomers are phenomenal, and I've used them for many years. But there is newer technology that it just offers a better solution, has better impact on the patient's health, and that's the Ceramir product, and these other ones that have the same ability, like I showed you, calcium silicates. They can self-seal as well. And so you have just new categories that are better technology. The same as we're not all using zinc phosphate anymore. I hope people aren't, or carboxylic acid cements. Hopefully you're not using that anymore either, right? Newer things have come along, and we've stopped using older modalities. Simple. Okay. Well, I'm not seeing any other questions here. So like I said, go to dentools.com. You can type in your comments and questions there. I'm usually pretty quick to get back to those within about 24 hours, oftentimes. But I hope you saw some great things, not only about the Ceramir, but maybe about adjusting ceramics, two cool products that are out there. You've seen some phenomenal ceramic primers from different manufacturers that make a huge difference with any of your ceramic work. We talked a little bit about resins as far as the chemistries and having MDP inside of them. So you got a lot of good gifts here, a lot of information that you can go back and maybe put to good use, or start to dive in deeper, do a little more research, and see that kind of the where dentistry is going. The surprising, this material has been around for quite some time, has great research behind it, and hence I share it because, like I said, I'm literally doing this all the time, and I've seen great results because of what I've read through research. And so I'm passing along some information here that may be beneficial to your patients as well as your business. So with that being said, I'm going to say happy holidays to all. Have a great rest of your day, and I'll look forward to seeing you maybe on social media. Thanks so much.